Hello, and welcome to Digital Decode with Qhala. My name is Laura Walubengo, and I'm your host for this podcast, where we'll be diving into anything that has to do with technology in Africa. And the aim of this podcast is for us to be able to decode anything that's happening digitally on the continent. As you know, the future of this continent is steeped in technology, and so you better be listening. What we're trying to do here is make sure that you're enlightened and inspired. Welcome to another episode of Digital Decode with Qhala. And today we're talking about data as it pertains to health. Now, health is a very big issue in Kenya, as you know. And the way that data affects health is something that not many people understand. And today on the podcast, we have Job Mosi. Job, I will not even try and dignify him with my own introduction. Job, please introduce yourself to the podcast.
Thanks, Laura. My name is Job Otieno, but most people refer to me as Job Mosi. I'm in the tech space, but how I'd love to introduce myself is that I'm an author, I'm a speaker, I'm a mentor, I'm also a friend, and I'm also a father.
Mhm.
Okay. So my expertise is in the tech space, especially in the financial sector, with a little bit of experience in the insurance sector, but I also am in the health sector with Qhala, mainly for the purpose of providing insights from the data we have to help make informed decisions um, when it comes to how best can the government, in collaboration with the private sector, provide accessibility, better healthcare to the population.
Mhm.
Yeah.
That's a bit of a mouthful, but I like the fact that you introduce yourself as a father, because I think
Yes.
that's a very important part of society, and
Yes.
the fact that you want to be recognized that way means it's a responsibility you take very seriously.
Very, very, very
And
seriously.
congratulations.
Thanks. Father of two boys.
Two
Yeah.
boys. There you go. You have a
Yeah.
lot of work. Eh?
Yeah.
But I think the definition I have of you
Mm.
is completely different.
Mm.
So I know you as
Mm.
an agile product delivery consultant,
Yes.
but I have no idea what that means. What does that mean?
I'm going to try and crunch it really, really to a chewable size.
Mhm.
So, as an agile product consultant, mine is to work with a team, lean team of people, with an aim of delivering value into the hands of the customer in the shortest time possible. So, ours is to deliver product through iterative manner, in the sense that we aim at looking at the minimum viable product or the minimum value that the product can offer to a customer, and they're willing to pay for it, and it's actually also able to provide value to them without having to put them in a corner or in a spot for several months. So one of the challenges that many organizations face is how fast they can actually put a product out there. And the problem with that is that, as you have seen in today's market, um, startups and organizations that are able to identify particular niche areas of the market that are not being met by the already established organizations, why they're eating much of their lunch is because they're able to address the pain points and the needs that the consumers are looking for. And they have the capacity to experiment and just not just experiment, but to be able to risk it all out there
Mhm.
and build a product that not just small niche people, a number of people are willing to pay for, yet that product has the capability to scale. So that is the space where we are in. So ours is to look at the market, the segment, listen to the consumers, what they want, be able to quickly build that and then put it in their hands and quickly experiment, listen to their feedback. If it doesn't fit, we go back to development and again we put it back into the hands. So we scale it up through several releases. So we may have like up to 10 releases within a year.
Mhm.
So the first release may have just a minimal bits chunk of what the consumer need, but by the end of the year, the release would be at maybe release number 10 or release number 20.
How did you get there? How does somebody leave school, study what you need to study? How do you get to be an agile product development consultant?
So it was really, I don't want to say it by chance. I think I was at the right place at the right time. Back then, at Equity Bank, we wanted to build. At that time, most of the bank was starting to digitalize and digitize its products and its offerings. So we were working under a fellow called Jack Ngare. So Jack had a very small team, small lean team, and he was tasked with the responsibility of digitizing the bank channels, moving customers from the banking halls to their devices. So the whole idea was, how can I better um, provide a better customer banking experience to consumers? So his vision was moving from a place you go to a thing you do. So it becomes a lifestyle. And for it to become a lifestyle, then it has to be easily accessible to you. And the most easily accessible device that most consumers have right now is their phones.
Yeah.
So how do we digitize the whole banking offering onto a phone? So at that particular moment, Jack had a small team, and the role he told me to play is the role to orchestrate the team in the delivery. So we needed to be able to understand, what are we delivering, how are we delivering it, what are the shortcomings, what are the challenges, who needs to address them. So it had to be. It was in a very the environment was quite was pretty rough and pretty
Rough.
pretty rough, because the bank was expecting a particular product and we had to deliver in the shortest time possible. So that is how I came about into the role. So how we built the product had to change from traditionally how other organizations build their product. So most of our products, how we built it, we move it from on-prem to what we call cloud, such that it makes it easy for us to deploy the solution in the shortest time possible, so that from the moment you have an idea to the moment it puts in the hands of the customer, it's seamless. So that's how I came into the role.
Actually, it's making me think. Do you think that most clients find it hard to understand that for any particular product, especially a tech product, it needs to go through very many iterations,
Yes,
and very many tests to be able to make sure that it works? Is that a challenge that I can say you face?
so it is a challenge. And the whole idea is to abstract it from the customer, because the customer doesn't understand your challenges. So all they want is a seamless working product. So for us is, how best can we put it in the hands of the customer? So for us, the whole idea is, let's look at and again, it comes to data. What are the most used capabilities by the customers? So let's focus on that first. Then later on, we add bit and pieces to it. Yes, there are challenges sometimes. For example, for a bank like Equity that has tens and millions of customers. So if you put out a product out there that um, has any form of shortcoming, then it comes back to the reputation of the organization. So it means that we have to be very careful um, on how we build and release. So we have to be very critical and intentional on how we put the product out there. So we have our releases are actually aligned, and actually we work with business owners who actually have contact with the customers, so we know where their pain points are, and those are the first things that we start to address before we address other things.
So here's a scenario. I know that you were very much involved in the summer project, which was quite key during the COVID period, when the COVID pandemic landed in Kenya. And now there was a flurry of activity. You're trying to be on top of, trying to make sure that the disease does not progress. So with SEMA as an example, your role as an agile product development consultant, how did the two tie together? What did you need to do at that time?
So that COVID-19 was quite unique to us. So regardless of what was happening out there, the whatever whatever was happening in Europe couldn't actually be compared to what's happening here, because the scenarios are quite different. So from the first time when the World Health Organization declared COVID as a pandemic to the time when the first case was reported, so we needed to understand our local context. What can actually lead to escalation of cases? So the questions that were being asked is, how fast will you get from case number 1 to case number 100, from number 100 to 1,000 and 10,000s like that. So we needed to understand, what can we do to flatten the curve in the shortest time possible using our local context and looking at the different scenarios. And this is something that had not been done before. So SEMA, and I'd like just to correct that, SEMA is not really a project but an organization. So it came by chance that the principals making up who formed the organization, from Dr. Thumbi to Dr. Lois and Dr. Shiko, somehow in their fields, for example, Thumbi is an infectious disease epidemiologist and also a vet. Lois is a infectious disease specialist, and then Shiko is a technologist, right? So in their past, in working with data, trying to model, so they discussed, how can we, looking at our local context, from the first person who was diagnosed with the disease or with the condition, how fast can it spread? Then also we look at the research that had been done in the past. For example, there was a case of antimicrobial resistance that was done that was somehow increasing. So using those models, so and also to put in the local context, for example, population, morbidity, economic status, how then will the diseases be able to spread as fast as possible? So then we came up with a model. So it was just a small team. And using the data that was there, we tried to come up with different models and applying different contexts to that model and seeing, how does the data change? How does the data change? So that then led to Dr. Shiko reaching out to someone in the government, telling them, hey, I think we have something that can help us make informed decision on how fast this disease can spread and how best we can manage it. And we think this can actually be helpful to the country in trying to flatten it out and not really cause a lot of panic, because I think we have the tools that are necessary to manage the condition, regardless of not having the resources that are there. But with the minimal resources we have, we can be able to look at the data and be able to project it and see how bad it can get. So that is how SEMA came to be.
So, I mean, just from what you said, two things have popped up for me. One, how easy was it to access this information that you're talking about, some of the research that had been done before? How did you know that it was going to be useful for you to come up with a solution for this particular issue? And two, how did you get the government to listen?
So first of all, we looked at what was happening out there. So we were looking at rate of escalation. How is it happening? What is causing that rate of escalation? So for locally, the research that was being done, it was mostly in small populations and also amongst animals. So for example, if a particular condition in a herd of cattle, if one cow or one bull had a particular infection, how then can it quickly propagate to the rest? So using that model, you try to replicate the same and see, okay, using this one as the context, how can it happen? Now, to get the government to listen is because they were in need. They were in dire need. Okay. So the president is in a situation where he needs to keep the country calm. And also people are looking at how, I think the most fearful thing that everybody was looking out for was the shutdown. Nobody wanted to shut down. So again, we were looking at, should we shut down the economy? We look at the scenarios, where will be the minimal impact? Okay. And if we're going to shut down the whole economy, what will be the whole impact to the country, to the people? So for the government, I think it was easy to get them to listen because they needed help. They needed expertise from somewhere else to get them to direct the country in a direction that will allow them to survive the pandemic and be able to get out of it and have their lives continue. So it was easy to get them to come on board because actually at that particular time, what they needed was what was science saying? That was the key question. What is science saying and how is it impacting the outcome? And how will it actually help us manage the situation at the long run? So it was easy to get them to listen.
Okay.
Yeah.
So in terms of, okay, you have the data ready now, you presented it to the government, they've made certain decisions. based on the data that they've received. As the disease progressed, I mean, it took a while before things calmed down. What could you say were some of the successes that you were able to see directly from your intervention as a data specialist, so to speak, in coming in resolving this issue?
So the first way, how fast can the disease spread? So we looked at where is it coming from. So most of the time, most of the instances, it was people traveling into the country were the highest risk. Okay. Then the next bit is the people they came into contact with. So that's where the directive of traceability. So who came in? Where did they go to? Who did they come into contact with? Who else did these other people come into contact with? So it became very important to be able to trace the movement of all those people. So then again, that came with directives such as quarantine. So the 14-day quarantine was not a fluke. So it was intentional that if you travel into the country, and because you're high risk, the first thing that we needed to do was to quarantine you to minimize the risk. And when you during quarantine, you needed to be away from other people. And if you had to be with other people, then actually your movement had to be curtailed in a way. Now, so that way, we minimize how much it spread. Now, the next thing is we looked at what are the most likely other activities that can make it escalate. Next is we looked at gatherings. That's why there was a directive to minimize gatherings. So gatherings within closed spaces was kind of banned. Okay, so if you had to gather, then there were a certain number of people that had to be there. It had to be within an open space. The social distancing had to be certain social distancing aspects had to be there. So that was also the other way of controlling it. Now, the other aspect was we looked at the economy, exchange of money, hard cash. So that's another way of easily, especially if I went to a clinic, it was quite easy. If I gave you hard cash and if I was at risk, I can easily pass it to the next person. So the decision then came to, can we encourage more of electronic money transfer? So, and how do we encourage people to move away from hard cash to electronic money transfer? Zero rate mobile banking transfer. So then we encourage more people to transact using the mobile phones or any other electronic means. So that way, we identified the risk areas that were likely to escalate the problem. And then we look at the solutions. What can you do to help minimize? We thought of, or maybe washing of hands, quarantine, minimizing social activities, encouraging social distancing. So that is how then looking at the data, then we see, okay, it's starting to calm down. Then the other thing was churches. So like, okay, maybe that's another potential risk. People going to church and to mosque. So
I remember there was actually not going to church as you were speaking.
Yeah. So for SEMA was more of a center of advisory to different people, to the CS10 of health, to the Director General of Health. There was the Security Advisory Council, to the sheikhs, the councils of then also to churches, to advise them that this is how we think best we can manage the situation. Then together they can advise the president. The president can give out a directive on what to do next.
Okay. I mean, it's interesting what you've just said, because I didn't realize that the decision to zero rate the costs of transactions was not economical. It was actually a logical measure. So how did it work? Was there like a command center, and in that command center you give feedback every single day, or how did the interaction happen? Just out of curiosity.
So it wasn't really a command center because that time I think we're distributed. So the whole idea was, how can you assemble a team that is able to work at a model? So create a model, iterate that model, look at the results. What is it saying? So it involved a lot of experimentation and willingness from people to learn new things. So the whole idea was, how can we collaborate? We look at what's happening in other countries. How are they managing it? How are they looking at flattening the curve. What are the inputs to their models that they're using? So those are the things that we would use. And so it was all about, again, comes to agility, experimentation and looking at the outcome, then feeding that outcome back into your whole model again, then again experimenting and iterating and seeing what the outcome is, then looking at the results, the visualization, then you say, okay, maybe this is how it's looking at. Then over time, we find that because of those activities, then the curve starts to flatten out in a way.
Okay, so in terms of doing these iterations of any kind of product, any product or service that you're testing, the trick is to make sure that you use the littlest time possible
Yes.
with each iteration.
Yes.
So at some point, let's say as you, how long did you need to test any particular theory or any particular idea during that time, considering there wasn't that much time?
There wasn't much time. So we'd go into, so we normally call it sprints or cycles. So we'd go to cycles of less than 24 hours, less than 12 hours. So it involved a lot of hours of working, trying to dig up data, trying to look at possible scenarios. So we look at different countries, different counties. So for counties, then again, we look at preparedness for the different health facilities to provide support. So you look at the most minute things like, do they have oxygen? How many beds do they have? How many support staff do they have? Do they have are they let's say if there's a health facility somewhere in Baringo, how well is it connected to a health facility, let's say to a referral facility, let's say in Eldoret? So you start looking at all those numbers. You look at the population around the area. How fast can they get to the health facility? What is likely to inform the decision to get to that health facility? So it involved looking, thinking outside the box, so if I may say, and because again, when it comes to modeling, you need data. And where do you have to? So we need to find different sorts of data that you can work with to try and come up with a model and a scenario that helps to paint the picture that this is how it looks like. Again, it went when the resilience to COVID-19, we looked at data like, for example, and that's why vaccination was being encouraged. You look at the people who are vaccinated at birth, BCG vaccination things. So we look at, maybe this could be the reason why there's a lot of resilience. That's why we're not seeing a lot of cases, a lot of numbers. So then it goes back to the little things that were done in the health sector from a long time ago in helping to manage this whole pandemic situation at this particular time. So having to add those, who was vaccinated, when were you vaccinated, which vaccine did you skip, which vaccine actually gives you a better fighting chance. So when you add all those inputs into the model, then you're able to come up with a scenario.
Where did you get that data? Like,
Now, interestingly, the government has data. You'll be surprised. When it comes to health, the government has a lot of data, and the government collects data on a monthly basis from the government has a definition of what a health facility is, from a level 2, a level 3, level 4, and they're all mapped out. So every month, each facility has a level of reporting that they have to do. So the government actually has that data, and they know how many people are vaccinated in a particular area, how many were not vaccinated, based on the vaccines that were distributed, how much was used, how much is still in stock. So the government has that data. So it was now for them to make that data available, because now as we're expanding our horizon, then because we need to start looking at the resiliency. What enables the resiliency? And we go back to the basics. And then they come, by the way, we have this data. So they actually encourage the government to give access to its database. Yes.
I have a question, but I'll park it for a second because I need to ask you something. So COVID changed a lot of people's lives, and it changed a lot about how organizations worked, how they shared their products, how they just changed things.
Yes.
Like you say, when churches were closed, now you had a lot more churches going onto YouTube, trying to reach their congregants.
Mm.
So how did things change for Qhala at that time?
So for Qhala at that time, so Qhala was launched in January of 2020, and in March the first case of COVID was announced. So that was less than 3 months.
Yeah.
Yeah. So that was March 12th. So for Qhala, it had to, how do I, the best word? It had to innovate itself. It had to rebirth itself in the sense that how do we remain relevant? Okay. And in remaining relevant, then you identify what are the opportunities that the current situation provide. Now, the opportunities that the current situation provided at that particular time was access to information and data, and not only access to information and data, but insights out of that information and data. So, how do we provide that information to the population? Okay, so we built a portal that helps to map out the heat areas. So you could easily look at that portal and be able to check, for example, which health facility in Baringo has a number of ICU beds. Okay. So the whole idea is in providing our products and services, how is it still of value to the consumers or to the people who need to use it at that particular time? And are they still willing to put some dollar or some shilling into it? So our innovation came about in relevance, and in relevance by ensuring that the product and service that we're putting out there is one that is actually needed and useful to the people. So that's how I think Qhala renovated itself or rebirthed itself.
I think it's been on a sprint ever since, because
Yeah.
there seems to be just more that needs to be done.
Mm.
So how do you deal with dirty data? Because I'm just this picture scenario. You have a dispensary somewhere, and this dispensary is slightly remote, and so there might be a staffing challenge. So you have a nurse who maybe she doubles up as the gynecologist in that facility, and then she doubles up as something else as well. So at the end of the day, maybe during the day, she doesn't have time to actually go through and input the data as the clients come in. Although it is a very tedious process. I know when you go to hospital, it's something that you don't realize. It bugs you because you're like, why do I have to go through all of this? But it seems to me, I can see how important that is. But how do you deal with dirty data where you have this lady who's completely tired and it's none of her fault? At the end of the day, she has 20 forms to fill, and then maybe she doesn't remember some of the details. So how could you tell what data could be used and what couldn't be used at the time?
So it actually comes out on the first instance when you try to visualize the data. So you get the data from where you get it, you transform it, then you visualize it. So out of that, as you're trying to pull out insight, you start to notice certain variations. A good example, for example, you might think that access to health facility, the shortest time it takes for someone to get to a health facility, Nairobi would have a higher success than Mandera. But then all of a sudden, when you look at the data and you look at the outputs, it tells you that apparently people in Mandera tend to access health services much quicker than Nairobi. And also, again, it tells you look at other marginal areas. It tells you that preparedness for health facilities to accommodate or take care of a certain condition, it tells you that it's much higher. So you go back and check, okay, maybe there's something wrong or missing in this data. So now, the government itself has two forms of databases. There's what it's called the Kenya Demographic Health Survey, KDHS, and then there's so the KDHS, what it does is that it accumulates data over a period of 3 years, 3 to 5 years. Then it crunches it, then it pulls out, it visualizes it. Then there's also the KDHIS, Kenya District Health Information Software. So that one is for monthly reporting. So the monthly reporting, it comes from every health facility. So they're supposed to report every month. Now, the good thing with it is that there's access to it. So sometimes you find that in the month of January, there's a health facility that did not actually report, for example, the number of vaccination that was done was never reported. But then again, in February, because they're always tasked, because someone always has to go back and say, hey, why didn't you report? So maybe because of that, they see the discrepancy. Maybe they go do another over reporting. So again, there's another discrepancy. But then now to clean it up, you go back again to the basics. For example, let me use vaccination as an example. So X number of vaccines was given out, were stocked. So we know that these are the number of vaccines that were given out and are stocked at each and every health facility. Now, these are the number of vaccines that you say that were given to the people. Other than that, you say that these are the number of vaccines that were dispensed. So in dispense could also means that other than being given to people, it means that maybe some were broken, some maybe were expired, so they're not part of the stock. So based on that, what you start doing based on assumption that you take out certain data, so you try and now start to normalize it. But also at the same time, the information back to the health people who are responsible for the health sector is that part of the reasons why we're having this bad data is because of maybe one, staffing. Because again, when you look at a health facility readiness, so we look at different parameters. One of them is, for example, a pediatrician, a clinician, things like that. So you may have a newborn baby unit in place, but you don't have a pediatrician. So maybe some clinician somewhere will be forced to double up. So you're told, yes, in as much as you have a newborn baby unit, but your readiness is still very low. So what can you do? You need to staff. So part of the reason why, for example, let's look at the recent strike by the intern doctors.
Yeah.
Part of it is because of the problems that are actually at the local facilities. They are seriously understaffed. So some facilities don't even have qualified doctors. They only have maybe clinicians or clinical officers. So that then in the end contributes to the bad data that you get. But you can only mitigate it by having the right people. So for example, you can say we can have in a particular area, even if you can't staff every single pediatrician, you can have maybe two who can maybe move around this area. So that then helps again with the quality of data that you get at the end of the day. So it's a mitigation process that we use. So first of all, we understand, we look at the discrepancies, try to minus, add, to try and make sense to it. Look at the previous year. Again, we look at what was the previous year like? Okay, these numbers don't make sense. What could have changed within that 1 year or 1 month or 6 months? So that is what helps us to mitigate when it comes to bad data.
Okay, so now we're living in a post-pandemic world. And one of the strong suits that I see coming out in the conversation is Qhala's interaction with data. What would you say some of the potential of data in solving even other problems, let's say, in the country, and even health related, just based on your experience and interaction with the SEMA project?
So beyond the pandemic, SEMA has evolved to a competency or a center of excellence. Like I said, SEMA is made up of mathematicians, statisticians, epidemiologists, data scientists, computer scientists, infectious disease specialists, all working together. Now, what happens is that now we go beyond that, beyond the pandemic, to see how best can we fortify our healthcare. Okay, so we start looking at different scenarios. A good example would be, for example, how can we enhance or reduce child mortality in the country? So we work. So the organization now starts working with county governments. So, for example, one of the works that was done with, for example, I think was it Qhala and also in Nandi, was they're trying to look at how best can we enhance or fortify our healthcare system. So they want to look at the number of beds that are available in all the health facilities, the number of support staff against the number of beds. So we look at the whole scenario and then we present it to the county government. Then from there, they're able to make informed decisions on what best can we do? Where do we need to add more human resources to help provide better healthcare system? How can I make it easy for someone who is, let's say, in Kawangware, easily access a healthcare service that is in, let's say, Kenya.Tech in the shortest time possible. And that's how maybe right now you find that even private sectors have come into play to collaborate with the government to try and digitize now healthcare services. So actually, you do not even need to go to to travel even 100 kilometers to be able to access healthcare service. So through your phone, you can easily access a healthcare service. Then, depending on the severity of the situation, then you can be advised on where or the nearest location where you can get that service before you consider traveling maybe 100 kilometers or 200 kilometers. So that is how now they're partnering with county governments and even other governments outside Kenya to help them fortify their healthcare services.
Okay. I just thought of one particular problem that I think Africa has, and I don't want to put you on the spot, but an issue like malaria.
Mm.
Do you think anything in the data that you collect and you analyze can make a massive difference in reducing the malaria deaths, malaria related deaths that we
Mm.
have?
Yes. So I mentioned the KDHIS reporting and visualization. So there are several parameters, and one of them is malaria in every county. So we look at the number of malaria cases reported, and we look at the age gap, the age groups, less than 5 years, 5 to 10, 11 to 10. We look at those. Where do we find most uh, prevalent cases in? Which counties actually are reporting increased number of malaria cases? Then, based on that, then you go back to that particular location, particular county. Then this is becoming a problem. So, what could be? Then you go now to the root cause. What could be causing an increase in malaria cases? Now, let me take another step. Cervical cancer, for example, in between I think April in June in Nairobi, the number of cervical cancer cases reported in women actually spiked.
Hmm.
And it was much lower. If you look at the same period over the last,
A few years.
not even few years, 6 months, 12
Hmm.
months,
Hmm.
they were quite minimal. So, what is causing that spike? Okay. So, now those indicators then help enable us now to give out information or insight like now what could be the reason why the number of cervical cancer cases are increasing in Mombasa, actually in Nairobi and Mombasa. Why are they going up? So based on that data, then the government and whoever is responsible can make informed decisions to help mitigate and reduce those problems. Maybe it could be something as simple as someone who's supposed to be distributing nets hasn't distributed nets over the past because it's supposed to be every month. Maybe was there a problem in the procurement,
Mhm.
in the supply chain? What could have
Mhm.
been? What could have occurred?
Mhm.
Is it that people have become more consumed with their issues that they no longer consider going to the nearest healthcare center to get their free net
Mhm.
to take home? What could be the issue? Then you go back and address those issues, and then again look at the numbers over the next couple of months and see how it's actually being mitigated.
I imagine as an end user of all this information,
Mm,
me going to whichever health facility or me being able to fill in the data.
mm,
At what point, like now, even the spike that you talk about when it came to cervical cancer, at what point does the information feed to the citizens? Because I think you've mentioned the two arms that actually give the government information.
mm.
Was there anything in that whole funnel that actually came down to now information coming to the citizens just to make sure that they take their responsibility
Mm.
in dealing with the whole issue?
So one of the things that we're trying to do is to build dashboards that is accessible to everyone.
Mm.
So it all comes down to democratizing information and data. So we build dashboards that can help people understand the going on within the healthcare sector. So not so so maybe there needs to be a lot of education and awareness
Mhm.
that actually these tools actually do exist, and they can actually use those tools to make informed decisions themselves. So if I know, for example, let's talk about cholera outbreak, that there's a lot of cholera outbreak in the urban centers compared to the rural areas. What could be the reason? Then I need to start taking care of myself. I need to start thinking maybe eating at the local vibandas may not be the best thing. Or maybe can we make more noise to make sure that there's someone at the health department of the city to actually take their work serious and check on why the level of hygiene in those cafes is actually reducing. So what you're trying to do is to democratize that democratize the information data by building dashboards that's actually easily actually right now, if you go for example to the SEMA site, there is a data analytics section, and within it you can actually access all that data from COVID-19 to as simple as malaria cases in a county, in which hospital, in which facility provides the number of BCG vaccines given in the month of January. It's all there. So it's just a matter of maybe awareness being put out there that actually that information is actually available.
Okay.
Yeah.
I know we've done this sort of the back way, but SEMA is actually CEMA. And I wonder if you could just tell us a little bit more about SEMA itself as an organization. I think you've spoken briefly about how it came together, and you've also spoken about the constituency of what SEMA is. But if I just need a definition of SEMA and how perhaps as an individual or as an organization I can interact with SEMA, what would you say?
So SEMA is an acronym for Center for Epidemiological Modeling and Analysis.
Very, very, very,
Epidemiological,
very sexy name.
yeah, epidemiological modeling and analysis. So it deals. Its main focus is on infectious diseases and how it can easily spread. Okay, then by making use of modeling analysis. So at SEMA, it's a consortium bringing together a multidisciplinary team. So, like I said, there are mathematicians, there are data scientists, there are computer scientists, there are infection disease specialists, there are epidemiologists, there are research assistants, and the objective is to prevent the next epidemic. Their objective is to bring about informed decision based on insights from data. So theirs is to regularly look at the healthcare space. Okay. So when you look at the healthcare space, it's quite broad, from maternity to what? It's quite broad. So they look at every single case and try to analyze it and try to visualize it. And based on that, then how can we best inform? It could be in the private sector or it could be in the government sector to make better decisions. Right now, the whole idea is to provide better healthcare to the masses. And also the whole idea is for the masses to access healthcare services. So we look at the numbers and across the country, what is hindering people from accessing healthcare. Then again, we look at simple things like knowledge. Sometimes it's just knowledge that lacks in certain areas, and we find that those who have knowledge in a particular area tend to make informed decisions on how best to take care of their health. And also we look at economic status. Sometimes economic status also sometimes impact access to healthcare or access to information. Yeah. So that is what. So it's in simple sense, it's a center of excellence that aims at providing informed decisions or insights based on the data that they have for particular categories of data. Then to whoever needs to make that decision, then we provide them with that information. Then they're able to make easily because it's backed by data. Yeah.
So the fact that I guess Qhala is a component of SEMA, and SEMA is playing a critical role in using data to come up with health solutions and to just have a knowledge base that I guess a lot of organizations can tap into, and especially government even, to be able to prevent certain crises in future. When it comes to that sort of setup, how else can other organizations partner with Qhala?
Actually, they're already partnering. So they are partnering. I don't think I'm the right authority to mention, but they're already partnering with governments, with foundations, and because again, it goes back to the first thing that they did. So based on that, people saw that actually, and by the just to come back to the basics of it. So the whole idea was to find a homegrown center of excellence
Mhm.
that understands the healthcare based on the local context. So right now, the whole idea is how can we grow the healthcare sector? Okay, based how can we use technology to make it easier for people and the masses to access health? So we look at the local context, and we do not use assumptions from other nations and maybe in Europe or in the Americas. So, but we use the local context. So based on that, because many are interested in alleviating the level of healthcare, so many are coming in and partnering with us, and also other countries that are already seeing the benefits of what SEMA does are also coming in and saying, hey, we need your help to help us do this and that. And that is how the partnership has been growing.
Okay.
Yes.
Okay. Congratulations on
I wouldn't
that.
say it for me, but I think that's the team.
No, I mean it
Uh,
is teamwork,
yeah, it's a
and I
teamwork.
think
Yeah.
that's the beauty of it because everybody's coming together
Mm,
for a higher reason.
mm,
We're all connected. I think that's one
mm,
thing COVID showed
mm,
us, that everybody is
mm,
connected,
mm,
and if you get COVID in Italy, it's very
mm.
easy for even
Yes.
somebody in Kenya to get it.
Yes.
So I think just to wrap up, based on the work that you do as an agility consultant, and based on just the importance of data that's emerging a lot more nowadays,
Mm.
how would you say going forward the perfect scenario would look like in terms of using data to resolve so many issues that we have just
Mm.
as a country, as a
Mm.
continent,
Mm.
that we probably need to be more cognizant of?
So what I can say that every sector, every organization has some level of data. Okay. Then so the biggest challenge is not even having the data. The biggest challenge is drawing insights out of that data. Okay. So many are sitting on data that can actually help them out of the situations. Let's take the example of maybe banking right now. One of the biggest challenges is people are defaulting on their payments. So why are they defaulting? Okay, we look at the economic uh, conditions underlying it. And if you look at Equity Bank, one of the things that they've come up with is the Africa Recovery Resilience Plan. So it's a strategy, not only aimed at Kenya, but also to the East and Central Africa region as a whole. So we know that over the past couple of years, and maybe over the next couple of years, there are certain challenges that are going to uh, put a lot of pressure on the economy and
Mhm.
on businesses, especially small businesses. So then it becomes clear that how these businesses and these individuals need help. Okay, and we know, and for us, we know that for the whole economy or for the whole financial ecosystem to survive, then every struggling organization, business, individual need to find a way to prop up. So based on that, we look at the areas that are most affected, and we say, how can we then pump in money to help them come back up? Then again, you look at the numbers. For example, maybe part of the reasons maybe because people are defaulting on their loans because their disposable income has reduced, so they don't have enough money to pay back their loan. So maybe then it comes, okay, can we then negotiate the amount of period that you can repay your loan? Can we reduce the interest rate? So we come into those conversations. So we look at the numbers and which are the most affected areas. So based on that, then the executives can be able to make informed decisions on how best to help them. For example, can we extend you a different sort of credit that can actually give a lifeline to
Mm.
your business? Which other product can we look at that you can actually utilize to help you keep afloat over the next couple of years? So every organization has some sort of data. So what they need to do is to pull insight out of that data. So it could be, for example, in the car insurance sector.
Mhm.
A good example could be why and this is a question I've always put out there. Why do I need to still pay the same amount of money for insuring my car every year in, year out? without you giving consideration to discount. Have you looked at my driving habits? Have you looked at other things, for example, my health? So using that data, can you be able to model a price for me? Maybe again, it comes to the question of, for example, why is insurance penetration still low in Kenya and all other African countries? Will it be because we do not, the insurance products that exist today were those that were modeled for the 80s and 90s and do not make sense right now? So how best can we remodel that to provide better products to the people? So it's just a matter of looking at the insights, looking at the data and getting insights of it. So every organization and everyone has some sort of data, but have to make insight out of it.
Yeah.
Yeah.
Okay.
Yeah.
Thank you very much.
Karibu
I
sana.
can't believe I've spoken about health for almost an hour.
Yeah, I can't believe it also.
No, but I think it's quite important for especially the dashboards that you're talking about, that people would actually go and check them out and see. Like if I'm traveling to Kisumu, for example, I need to understand what's happening there.
Yes, for example, is there a cholera outbreak over the past couple of months? What are the rates? Has it been going up? So those can actually help you.
Okay.
Malaria,
Malaria, especially. Yes. I think I got so much malaria when I was growing up. I think I'm immune. They should probably test me anyway. But thank you so much. Thank you for your time.
It's been a pleasure.
Thank you for coming onto the podcast. I hope to host you again, actually. I think you have some really good insights on insurance.
Yes. Please call me back.
Okay.
Yes. Thank you.